Have you ever wondered how we know some foods are better for you than the others? This is nutrition research. There are two types of nutritional studies: observational or randomized control studies. Observational or cohort studies measures the association between the exposure to a nutrient and its outcome. For example, does increased intake of vitamin D decrease the chances of catching anemia? There are three types of associations. The first one is the positive association, which indicates that a higher intake of the nutrient would lead to an increased risk of developing the disease. The second type is the inverse association, which indicates that a higher intake of the nutrient would decrease the risk of developing the disease. The third type is no association, meaning that your exposure to the nutrient has nothing to do with the outcome of the disease. However, the observational study does not come without its limitations. The observational study does not take into effect the confounding factors. So, for example, if a higher intake of coffee has shown to increase the risk of cancer, the people who have been tested for it might also be smokers, which might also have contributed to cancer. But because uh, smoking is a compounding factor and has not been taken into effect in this experiment, it might not be as effective. One way that observational study can be carried out is by using a food frequency questionnaire. A food frequency questionnaire asks the participants how often they've intaken a food. Now, a frequency food study needs to be validated to ensure that there's no bias and there's no mistake. We can validate it by comparing it to the standard. It is important to note that an outcome measured by the observational study is either a disease or a risk factor. A disease can include anything of stroke, myocardial infarction, cardiovascular disease, or pulmonary embolism, while the risk factors can be blood glucose, hypertension, inflammation, or blood lipids. The second type of nutritional study is the randomized control trial. In randomized control trial, there's a control group and there's a treatment group. The population in the control group doesn't face much changes in their diet. However, the population in the treatment group faces substantial changes in their diet. Unlike observational studies, in randomization control trial, the confounding factors are equally distributed between the control and the treatment groups, and the only difference between the groups is the treatment. Randomized control trial is usually conducted through something called a blinding study. Now, the blinding study is when either the participant or the researcher don't know which group they're being assigned to. Double blinded is when both the participant and the researcher don't know, and single blinded is when either the participant or the researcher doesn't know. However, randomized controlled trials also comes with its limitations, as it only measures the risk factors of a disease rather than its hard disease outcome. It's also difficult to sustain, especially if you're making substantial changes to your diet. One myth about the randomized control trial is that they're perfect. However, that is not true. For example, in a study done by Pre-Diamond Trial on Mediterranean Diet, it had to be reanalyzed due to having many human errors. In nutritional research, there's something called a p-value. The p-value tells you the likelihood of an event or an outcome happening due to chances. P-value is a number between 0 and 1. If the p-value is under 0.05, that means that the likelihood of the outcome being due to chances is very low, therefore making it very significant. If the p-value is above 0.05, that means that the outcome likely happened due to random chances and there is no statistical significance. One myth about the p-value is that if it's under 0.05, the treatment definitely works, but that is not necessarily true. For example, the ARRIVE trial tested whether a low dose of aspirin could prevent fresh heart attacks in people at moderate risk. Although the researchers looked for differences between aspirin and placebo, the overall benefit was very small and there was an increased risk of bleeding, proving that the p-value alone is not enough. To determine whether nutrition intake affects disease risk, we measure something called the relative risk. Relative risk compares the risk of disease in an exposed group, for example, people consuming high amount of nutrition X, to the risk in a reference group. If RR equals 1, there's no difference between groups. If relative risk is greater than 1, there's increased risk, and if the relative risk is less than 1, there's decreased risk. Key takeaway is that nutrition research doesn't just ask whether something works, it asks how we know it works. By understanding study design and statistical interpretation, we can move beyond headlines and evaluate evidence based on scientific principles.